We move to the beat of our hearts tonight on Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. You break it when you lose your first love. You feel it skip a beat when the roller coaster goes over the first drop. And it glows with warmth when you read your child a story. Our hearts, they do so much for us. What can we do to keep them strong? We're On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Tonight we examine the health of the heart, cardiology, and cardiac surgery. We have two knowledgeable guests to help us learn. First, we welcome Bruce Watt. FACC is a cardiologist in Sioux Falls, South Dakota, and is affiliated with the Avera Heart Hospital of South Dakota. Dr. Watt, tell us a little bit about yourself. Where are you from originally?
Well, Rick, I grew up in Wyoming and went to medical school down at Creighton University. Started out in family medicine, on to internal medicine at Mayo Clinic, then came back.
Practiced internal medicine.
I practiced internal medicine and did that for about 3 years in Sioux Falls, and then went on to the University of Wisconsin in Madison, Wisconsin, trained in cardiology, and then came back to North Central Heart.
So you've been in Sioux Falls for how long?
You know, off and on since I met my wife in '84 for 30 years.
Okay, and you've been with North Central Heart?
For 20.
For 20, all right. And also joining Dr. Watt is Stephen Feldhaus, specializing in cardiovascular and thoracic surgery at North Central Heart in Sioux Falls. So tell us a little bit about you.
Well, Rick, I was born and raised in Omaha, Nebraska, and I also went to Creighton University Medical School. And from there, I went down to Phoenix, Arizona, and did a 6-year general surgery residency. And from there, I went to Kansas City, where I did my cardiovascular and cardiothoracic fellowship.
And after about 2 more years, you're old enough to retire. I mean,
Yeah.
You know, after all,
Right.
That's a lot of training.
Yeah, it's a lot
Steve.
of training. You got to be old, but
So-
it was fun, and I'm glad I did it.
So you're related to the Feldhauses in South Dakota from Presho?
Presho, my dad grew up, was a farm boy in Presho. He also went to medical school and was a surgeon. And
Did he train in South Dakota?
No, he trained at Creighton University also. So, yeah.
So we have a general surgeon who goes on to thoracic and cardiovascular surgery.
Correct.
We have an internist. First family decided to do internal medicine, practiced 3 years, and then now doing cardiology and intervention cardiology. Right. So we've got the experts in heart health right here, both sides of it. It's a fabulous panel that we have tonight. We need to have your calls. Call us about heart health or heart disease at 1-888-376-6225, or email your questions to ask@oncalltv.org. That's oncalltv.org. So let's just in general talk about the most common things that you do with your day. What's your most common thing that you deal with?
Well, typically I come to the hospital and usually have patients make rounds, but we like to start our operative cases early in the morning at 7:30 and do as many as we need to that day, and that takes up most of our day. And then throughout the day, Dr. Watt and his colleagues will have consultations that we need to see, so we'll do that, and hopefully by the end of the day we get everything done and can get home at a decent hour.
So, and then you're on call every
The surgeons at the heart hospital take their own call throughout the week, and then on the weekends we have one surgeon that takes the cardiothoracic call and another surgeon that will take the vascular calls.
Call.
Yes.
So you do the vascular work as well?
I do a little bit of vascular work. We've got a team of three partners there at the heart hospital who are excellent at what they do, and they do the majority of the vascular stuff for us.
So, and if you looked at the percentage of things that you cut on, what percentage are coronary bypass, which are valves? What else do you do on vascular work?
Well, in the past, it would have been coronary bypass, but that's changed now with the techniques that interventional cardiology brings to the table. They're able to do stents and angioplasty and different things now, so the numbers of cardiopulmonary bypass or the bypass procedure have decreased around the country. Now with the aging population that we see, people are living to an older age. We see a lot more valve disease than we ever have, and I think that's probably becoming one of the mainstays of my practice is valve disease.
We should talk about rheumatic heart disease too sometime a little bit later. Bruce, so what amounts to your day? What is your day like?
My day usually starts 7:30. We usually will have a few patients to see in the hospital. Then we'll have clinic patients, and then scattered throughout the day we'll have procedures, heart catheterizations, an angiogram where catheters placed now quite frequently up the radial artery or in the groin.
Not the groin, but mostly in the arms now?
I actually, this last year I did 60% by radial and about 40% by groin.
It depends upon what kind of arteries they have.
It depends a lot that way, but most folks can have a radial approach. But then in addition to that, if it's necessary at the time, we also perform the stenting procedures, sometimes in the same setting if the clinical scenario dictates that. And then finish up with office patients in the afternoon, and if you're on call, then start the call duties at night. Fortunately, I have more partners. I don't have quite as much call.
Yeah, so you're on call every...
You know, we have 6 interventionalists, so we rotate. So somebody has to be on what's called interventional call, a physician who can open an artery in the setting of a heart attack. So every 6th night, then on average through the year for that type of call.
Are you called in most every...
You know,
it's 50-50?
No, I'd say 50-50, and sometimes multiple times on one night, and then you'll go a couple times where there are not any emergencies. But.
So the emergency opening with an acute MI that happens right then, and you can stop the progression of the heart attack. Tell us a little bit about that. What do you call it, and what is it all about?
Well, we call it an ST elevation MI oftentimes, and fortunately we've been able to work with partnerships of all the hospitals within South Dakota and Sanford and Avera. We've been able to establish with the Helmsley Grant Foundation, Mission Lifeline, so we have a standard set of orders that we're utilizing at point go, whether the patient's coming from Presho or Brookings. We have a standard approach. Medications are given to that patient. If it's a patient that can get to our catheterization lab within 60 minutes, we don't give the clot buster that we sometimes used all the time before we did stenting. And then the patient arrives and we rapidly go to the catheterization lab, and either through a radial approach or a femoral approach, we run a catheter up to the level of the heart, take a picture of the vessel, and then open the vessel, place a stent, and restore blood flow.
Yeah, you know, that has changed so much about what's happening with people in the ages before the catheterization and even the use of the clot busting drugs. Yes. I mean, they'd come in, would put them in the unit, we'd say a prayer, and hope that the heart attack is a small one, and then deal with it when it was all over.
Right.
And now we can intervene and open it up and reverse the whole process. Sometimes we have to use those clotbuster drugs. Tell us a little bit about those clotbuster drugs.
Well, the medications we predominantly use now, TNK, genetically engineered medications that actually go to the site of the clot that forms where the heart artery has been injured, and by attacking that and breaking up the fibrinogen clot that is there. It dissolves the clot in about 75% of patients.
Yeah.
It's effective.
That's the old streptokinase, but it's genetically changed.
Genetically changed, you bet. Yeah.
And you can stop that. You open up the vessel, and then you look at it again, and then you go, oops, this is the left main. And Dr. Feldhaus, we're going to need to have you do bypass tomorrow. Is that how that goes?
Well, and sometimes it's a combination. We really kind of a collaborative effort where sometimes we'll get a patient who has severe disease that should go to surgery, but they're in the midst of a heart attack, and our patients will do far better if we can at least just fix the heart attack vessel, stabilize them, then have Dr. Feldhaus see the patient and electively arrange for surgery after they've healed from that heart attack.
So I started practicing a significant time before you guys, and it makes me think about how radically things have improved. Yeah. And you know, we've seen that drop in cardiovascular death. Steve, would you remark on that? I mean, what's the differences now from the 70s, for example?
There's no doubt about it, Rick, that with the techniques and the knowledge that we have now, I remember days during my training in Kansas City where these patients would come in, they'd ask us to operate on it, and the mortality was very high. And then we soon learned to treat them first, and then settle things down, and then gather around and figure out what to do next. And over the years, we've gotten better and better and better. And I think the judgment of what we do with these patients has really improved over the years more than anything.
Yeah. Now, there's a discussion about angioplasties. I mean, if you read the Reader's Digest or the Consumer's Report, or you know, the Mayo Clinic letter, or whatever, the Harvard letter. Because our people, many of them would, they've said, well, angioplasties don't reduce death rate or heart attack rate. But there's something not quite right about that statement. Bruce?
Well, you know, it has to be taken into the context of each individual patient. Clearly, if a patient has a very stable complex of symptoms, a 75-year-old woman who has been gardening, enjoying life, and has been telling her family physician she gets a little bit of chest pain when she works a little bit too hard, but it settles right down when she stops, and she comes into the office and we do a stress test and it's abnormal. We say, well, we need an angiogram, and somebody says, you need a stent. May not necessarily be true. And in fact, her mortality rate, given appropriate risk factor reduction and doing all the medical therapy that's necessary, she could do quite well with the same mortality, the same repeat heart attack risk, by treating it medically and not always having a stent. And I think that's why nationwide the number of stenting has come under a bit more scrutiny through the American College of Cardiology efforts to be sure that we're having the guidelines to treat not just the old oculostenotic reflex. You see it narrowing, fix it. And in fact, a lot of times the vessels that we were fixing routinely are probably the most stable. You know, people think 90%, oh my God, it's going to close, but usually that's a 90% blockage that's developed over an 80-year-old's life, very firm. It's just a rate-limiting step. If you work too hard, you get short of breath. The ones you really need to worry about are the 40 and 50-year-old patients who are not addressing their risk factors, have a 50% blockage, which is the more likely lesion to rupture and cause a sudden death.
Right. So which are the ones that you cut on? Because some people get stents and some people get bypass surgery. Steve, who do we go?
Typically, if you to narrow it down real simple, there's the patients with minimal coronary disease versus the multi-vessel coronary disease patient. We'll get the multi-vessel more often than we do the 1 or 2 vessel bypass patients nowadays.
And so it's left main equivalent or more than 3 vessel?
Left main equivalent, 3 vessel disease is what we'll typically get.
So, and the left main is, what is that?
Left main is the single artery on the left side of the heart that comes off of the aorta. It comes off as a single artery, and then it branches into the 2 main arteries that supply the left side of the heart, the left anterior descending and the circumflex. So if you have a lesion in that left main portion, it's upstream of everything. If that artery goes down, you lose your entire blood supply to the left side of the heart.
And you're dead.
Yeah, most people won't survive that.
Yeah. And if they do, they've got such a weak heart now they can't function.
Right, correct.
Our hearts beat over 100,000 times every day. It's easy to understand that something can go wrong. Let's take a closer look inside the heart to see how it functions and some of the problems that might cause our heart to get all tuckered out. Let's take a tour of somebody's heart. Seeing is believing. Here is an actual angiogram showing X-ray dye spreading down a normal coronary artery, going out to smaller and tiny arteries and arterioles, feeding the heart nutrition and oxygen. I should point out that the heart gets its oxygen from these vessels, not from blood within the heart. Here's another angiogram of a constriction or closing off of a coronary vessel by atherosclerosis. And finally, this angiogram made following the dilation of a constriction and the placement of a tiny metal stent to hold the vessel open. Here is an actual echocardiogram made by sound waves showing the actual squeezing and relaxing of a normal heart. You can see the right ventricle into which blood flows from the veins and right atrium, and from which blood is pushed into the lungs. Here is the left atrium, into which blood flows from the lungs, and from which blood flows through the mitral valve, and this is the mitral valve, into the left ventricle, the major chamber that does the lion's share of pumping blood out into the body. Here's the aortic valve that opens during the squeeze and slams shut when the ventricle relaxes, keeping the flow moving forward. Here's a cross-sectional view of a normal left ventricle showing the donut normally squeezing out about 60% of the blood within during each squeeze. This makes for efficient flow when valves work and allows forward motion and nothing backward. This is a 4-chamber view of a normal heart. On this side is the right ventricle, and on this side, the left. Here is a cross-sectional view of a normal aortic valve showing 3 cusps, closing like a Mercedes-Benz logo. Here is an echocardiogram of a person with leaky valves. The blood is flowing the wrong way, backward through the aortic valve up here, right there, and backward through the mitral valve down here. This cuts down on efficiency of flow. Here is a calcified aortic valve, which is going to give this person a great deal of trouble. And here is the actual echocardiogram of that person with this calcified aortic valve and whose walls are very poorly contracting. We estimated that the ejection squeeze was about 10%, which is barely enough to live. She did live, though, for about a year after this echo, but was very limited in what exertion she could do. Here's a cross-sectional view of that same person showing the front part of the heart moving paradoxically. In other words, dilating out when it should be squeezing. And in giving us an idea that it isn't just the aortic stenosis, but that she had had a heart attack prior to this, that lost blood flow to that area of her heart. And that's also why that heart was so weak. Indeed, seeing is believing. How marvelous the heart can be, and how it can look when it isn't working right. Don't forget now, we need your questions, 1-888-376-6225, or email us on oncalltv.org and ask a question. We appreciate them. We've got a bunch. I thought that was a fun effort to do that little video inside the heart. It was hard. You know, I have a new respect for the TV weathermen. You know,
right.
What I mean? You got to look at yourself over here, and you got to go.
That's right.
Because there's a green screen behind you. We have a call from, or any comment about that echo or that thank you, by the way, for sharing that angiogram.
Yes, no, that was
The one that you did that day. You sent it to me that day.
that day. Well, and that particular patient did have an indication to do a stent. It wasn't just, we saw it, we knew enough about her. She'd been struggling with symptoms that had been misdiagnosed as reflux for about 3 years, and
There is truly an indication for angioplasty when they're having dysfunctional pain, and it can be really bad. No question about it.
Well, typically that's the type of patient I was alluding to, 10, 15 years ago, the surgeon would be called.
Right.
And we'd do a bypass, but now with what he can do, the patient's in and out and a short stay in the hospital and they go home.
They can now walk, they
Yes,
can now exert,
right.
they can function a lot better.
The only other thing I would comment, though, he underplays the role of the cardiac surgeon. In the early days of angioplasty,
Yeah.
We could not even start a case unless we had an operating room available. We did not have stents then.
Right.
We merely put a balloon up in the artery,
Dilated it.
dilated it, hope for the best. Didn't always go well.
Most of the time, though, they did. They
They went
okay.
pretty well, but the operation rates were about 8 to 10% of
Really?
patients in the early days.
Had to go to
Had to go to
surgery
an emergency.
right
These
after.
guys had a horrible lifestyle.
Yeah.
Now
almost as bad as yours.
now we open them at nighttime and they do them 3 weeks electively.
Yeah.
It's a little easier.
It's a
Well,
little
there's
easier
only,
now.
There's only 3 of you. There's a bunch more of you.
Right, yeah, we can't
But they
forget
really
that.
did support. They really did support the angioplasters in the early days of doing what we're doing to perfect it to where it gets a much more reliable result.
Right. We need your questions. We love your questions. Give us your call. 1-888-376-6225. From Sioux Falls, does chemotherapy affect the heart? And can a heart condition limit how chemotherapy is used? So chemotherapy, that's going to go your way, Bruce.
Excellent question. Certain forms of chemotherapy can traditionally, doxorubicin, adriamycin, which were medications that had been used in breast cancer patients.
Primarily.
They had to be monitored very closely with the milligram amounts. There are newer drugs which have cardiotoxicity. I'm finding that with the vast array of new oncology drugs, that oftentimes our oncology colleagues are even more up on it than some of our cardiologists.
But it does cause heart failure. I mean,
It can cause heart
adriamycin used to be the big one. They call for an echo before they do it,
Right.
make sure the heart can squeeze.
And the oncologists know, and they're continually always rechecking the echocardiograms, making sure that the function is being maintained, and very cognizant of it. But yes, chemotherapy can cause it.
Right. And then can a heart condition limit how chemotherapy? And the answer is you just said that,
Yes.
that it certainly can.
Can.
If you've got a weak heart, you're not going to be using that drug.
Right.
Do docs in Sioux Falls do surgery that reduces the size of the chambers for congestive heart failure? I know that at the Mayo, sometimes they'll do reduction surgery for the size of the heart. Steve?
No one that I know of in Sioux Falls does, and in fact, there used to be an operation where we did that, and I think that's pretty much fallen by the wayside. There may be some tertiary, larger centers around the country that still may do that, but
Cut
Right,
out these
right,
aneurysms and
right.
make the heart size.
well, the actual ventricles and cut them. Now, if you have an aneurysm, a ventricular aneurysm related to a previous heart attack,
Right.
that is something that can be dealt with surgically.
And you do those
Yes,
in Sioux Falls?
and we do. You don't see them very often, but when they do occur, and there's a component of congestive heart failure that you think is related to that ventricular aneurysm, yes, there is an operation that you can do for that.
I know there's an operation for what used to be called IHSS, but is now called hypertrophic obstructive cardiomyopathy, where part of the muscles thicken and get in the way of the aortic flow coming out the aortic valve. And I know I've had 2 patients get that surgery at the Mayo. Do we do it in Sioux Falls?
No, we don't. I've done several of those in the past. It's become a pretty specialized operation now, and I know the guys at the Mayo Clinic do quite a few, or at least I think they do, and they do a very good job. It's a delicate operation that you need to do because you can get into trouble fairly quickly. If you don't take enough of that muscle out, then you don't get the result that you need.
So you've got to take enough of it.
You've got to take enough, and if you take too much, you find yourself in trouble. So it's an area that I think if you're going to do that, you need to be doing quite a bit of it.
Yeah.
And there's an interventional technique for interventional cardiologist patients that can't undergo an operation can have an alcohol septal ablation, actually causing a heart attack in that area.
Yeah.
But again, not practice there. It should be done only in the hands of. There's a lot that goes into mapping out how much of the heart muscle is going to be affected by obstructing that artery. But so there are non-surgical techniques to be able to deal with that as well.
Squirt a little alcohol, a little bit more. Just a little bit. I think we'd take a little bit more. So it's a tough.
Not without a risk.
No, one patient who had a myomectomy of mine that passed away from it, and so they're, or very close to the time that the surgery occurred. Here's from someone in the 50s, caller had a heart attack and multiple stents were placed. What are the odds of having another heart attack and fixing the stents? So that's the question of, a stent's placed, and therefore how long is it going to last? Or even a bypass is done, how long is that going to last? And I would make one comment. I don't think we give enough credit to our own body's ability to do healing, to make its own collaterals and to redevelop blood vessels. That's been my opinion through the years, and so I've really been more of a conservative guy. What's your take on both of those? I asked you both that question. Bruce?
Well, I'll address the stent issue. Stenting has been a vast improvement in outcome in angioplasty and percutaneous treatment. Original stents are what we call bare metal stents. And even our best bare metal stents in arteries that maybe were of moderate size, there still was anywhere from a 25 to 30% chance that stent could re-narrow within the first year, and even higher risk in diabetic patients. Fortunately, the techniques have evolved, and we have drug-coated stents, which actually have a chemotherapeutic agent on it, paclitaxel or sirolimus. But these drugs help prevent the ingrowth of the fibrous tissue that can grow within a stent, and that has dropped rates into the 5 to 10% range. So if this gentleman had stents put in that were either drug-coated or large vessel, 3.5 millimeter greater than a bare metal does as well as a drug-coated, he has an excellent prognosis of that stent not closing. One of the big problems we see, though, are people not being compliant with their dual antiplatelet therapy. They're oftentimes on this clopidogrel or Plavix and aspirin therapy, and have to be on that for a full year and then aspirin indefinitely.
Right.
So that's the importance of following the medical regimen.
So the chemotherapeutic drug exudes off of the metal forever, or does it kind of wane away after
one of the reasons that it's usually a completed process within the first 2 months. Bare metal stents are almost completely after the first 2 weeks. But we have endothelialized. If you looked inside, you would no longer see that metal. You just see your artery. And however, there are cases of a late stent thrombosis because the chemotherapeutic agent works so well. There may be areas of the stent that aren't covered even out 7 and 8 months, and that's the importance of continuing that therapy until we're sure we're out long enough that it's been endothelialized.
All right. Your comments?
Well, we do see those patients that have had multiple stents, and a lot of times they're younger people. You want to try to stent them, keep them out of the operating room as long as you can. And the thing about it is, if you got a bypassable vessel beyond the stents, then you can go ahead and do the bypass. Sometimes that's not possible. The stents have taken up areas, and you don't have good targets, is what surgeons look for. And then you end up telling them that there's, the benefit from surgery is going to be low versus medical management or some other form of treatment.
So people talk about, okay, well, I've had my stents placed, and I've been told they only last 8 years. I'm having chest pain now at 6 years, or I had him 20 years ago and I'm just fine. What does that mean? Bruce?
That they're living a good life. No, it's
the quality of their
life. No, there's really no time frame you can put on a stent. Really, in general, if you get past that first 1 to 2 years without a stent complication, either at the entrance of the stent or within the stent, typically, if someone comes in 5 years later with chest pain, it's a new region. I see it a lot in my patients that have had bypass surgery. They're at year 10 and they're biting their nails. They just think the shoe's going to drop and they're going to die because they were told it's 10 years.
Yeah.
But much to your statement earlier, the body has an amazing healing ability, and the type of artery grafting that Dr. Feldhaus does with artery-to-artery graft, you can lose all of those vein grafts because over time your heart can grow those collaterals. It gives it time to do that over time,
Right.
and so it's tough to put a number on it.
So I know that you guys are probably fans of statins and so on and so forth. I'm a believer that there's a lot more on lifestyle that we should emphasize. Let me throw that at you, Steve. What do you think? How important do you think lifestyle is?
I agree.
To keeping that stent
I'm
or
a big
bypass.
proponent to lifestyle. I like statins, but I'll tell you, if you can get a patient, for me, a patient of mine that came to the operating room with my bypass, I want my bypasses to work as long as it can. So I always tell them, 50% of what's done is what I do. The other 50% is when you leave the hospital. And you gotta be active, you gotta quit smoking, you gotta really nail down your diabetes, you gotta nail down your cholesterol, eat better. I think all those factors together is what is gonna have a better patency rate for my bypasses down the road. And I definitely believe in lifestyle changes.
A lot of doctors keep saying this smoking thing. Are we carrying it too far, or how important is this smoking thing?
No, it's very important. And smoking is, you talk to any surgeon that does a bypass, whether it's peripheral vascular or cardiac or coronary bypass, that's probably one of the things that'll take down your bypass graft quicker than anything else. So it's very important.
So what is your comment about lifestyle, Bruce?
Well, lifestyle is very important, and we all try to achieve it.
Yeah.
And I talk about lifestyle year after year after year to my patients, and they look at my waistline and say, well, you haven't lost that weight either, you've got to get it. But it is critical, and it's not just, it's just not a little bit of lifestyle change. The lifestyle that got us into the trouble over our entire life is going to take time to change. But it can be drastic and quite dramatic if you do adopt a diet that can drive your low-density lipoprotein down, raise your HDL, and become physically fit and stop smoking. It can do as well as medicine's recent journal article we talked a little bit about, showing very, very effective rates of prevention of first-time heart attack.
By diet and exercise.
Diet and exercise. Not to say that statins aren't good, and it's something we have to fall back on because not all of our patients
are going to do those things. My comment is that it isn't the waistline that matters. It's that exercise and the diet. And people don't lose weight. Even if they go on the perfect diet, they don't lose that much weight. People seem to get a size that they're going to be, and that's what they're going to be. I mean, so I'd say forget the weight so much. Look at your diet and increase your exercise.
Yeah, I hadn't thought of it that way until I told my dad at age 65 when he weighed 310, and I just got out of medical school. I said, Dad, you got to lose weight.
And what did he do?
Age 70, I told him the same thing. He was 308. Age 75, 320. Dad, I said nobody lives to 80 that's that big. Turned 85, he was 310. He turned 89, and at last week's wedding I said, have another piece of pie.
Yeah.
So you're right. I think there's something. It's not just weight. It's a lot of different things.
And we don't know why people, I've done a lot of weight research, and I was involved with weight research at Emory in Atlanta when I was teaching there. And the answer is people get to a weight and it seems like their body sets at it, and no matter what you do, they can lose a little bit and then they'll regain it, unless you do surgery, which I'm not a real fan of. So, from Sioux Falls, recently had an angiogram, eligible for bypass, told him to try time-released nitrate, started it, feels okay. How long can he stay on this, and how long can he expect it to be effective? He's from Millbank. I misspoke. Time-released nitroglycerin.
I'm not sure about that one.
My true answer is I believe in short-release nitroglycerin. I don't use a lot of time-released, long-acting nitroglycerin. He's doing fine. He's probably clinically better, but it isn't likely the nitroglycerin. I was here when we got into, I was smearing everybody with nitroglycerin paste. I mean, I had paste on everybody. And then we learned that if you had it on all day, it was ineffective. You got to have this break, and then you learned it's got to be a bigger break, and then people would forget to take it, and it didn't make any difference. I think long-acting nitroglycerin is not that effective. Maybe in this man. Now, you're going to disagree with that.
Assuming if he was told that he had 3-vessel disease that needed surgery, and he opted not to have surgery, right? And I was telling Steve this on the way up, because we hear this a lot. What about chelation? Can I do chelation? Can I do this? Is there an alternative? And everybody can be treated with medication, but we deal in statistics. So if I could have given him snake oil from Dr. Hook's medicine show, and at the end of a year, there's an 85% chance he'd be back and say, this stuff is great, or chelation, or that. But unfortunately, 15 people would be dead at the end of that year. And it's those 15 people that if Dr. Feldhaus operates with a low mortality rate on, we save 14. And that statistic keeps going year to year to year. So it's
worth considering. Well, what we eat plays a big part in keeping our hearts working best, as we've said earlier. On the bright side, eating well does not mean complicated recipes or giving up flavor.
A heart-healthy diet typically focuses on foods high in fiber, low in salt, and also that contain low amounts of saturated fat. A Mediterranean diet is an excellent example and guide to follow for a heart-healthy diet. The base of the Mediterranean diet contains high-fiber, plant-based foods, such as fruits, vegetables, whole grains, and legumes. These will help maintain your cholesterol at a low level and also help with weight management. Make sure you're choosing lean proteins and varying them throughout the week to include at least 2 servings of fish. Limit your saturated fats and include plenty of heart-healthy fats such as olive oil and canola oil. And last but not least, use herbs and other spices to season your food to cut down on the salt. Today we're going to make a fresh black bean salsa, which is a recipe low in fat, low in salt, and high in fiber. First, we're going to cut some vegetables. We're going to cut onions, peppers, tomatoes, cilantro, and really any other vegetable that you might enjoy. Dice the vegetables into small pieces, and we're going to mix all of them in a bowl. We've already added some tomatoes, onions, and pepper. We're going to add more tomatoes, some green pepper to the red pepper we've already cut up, more onion to go along with the onion we've already prepared, some drained corn, a can of black beans that I've also drained, and some chopped cilantro for a little bit of extra flavor. This recipe is best if you let it sit in the refrigerator so the flavors will marinate overnight or at least for a few hours, but can be served as such as it is right now. You can serve it on a salad or with a piece of meat as a garnish. You also can serve it with chips. Today I actually baked a pita. You can take a whole grain pita, such as this. I brushed it with olive oil, cut it into small pinwheel shapes, and baked it for about 10 minutes. So it's a lower fat, healthier, more whole grain version than using a chip. And there you have a heart-healthy, high-fiber, whole grain snack, or something you could almost even make a meal out of.
Thank you, Katie. Wasn't that absolutely sounding delicious? Mm-hmm. So the last blurb was about salt. Now there's been a lot about salt, and recently now they've said that if they give nursing home patients all the salt they want, or if they limit their salt, there's not been a difference in how they've done. I would throw that at you, Bruce. Have you? How do you feel about salt?
Well, two real issues. If they're talking about hypertension, maybe you can be a little more liberal. Only 40% of patients are even somewhat salt sensitive. But if you're talking about congestive heart failure and fluid retention, absolutely have to watch the salt. The whole issue there is a total sodium fluid content, and a patient that has a tendency for congestive heart failure or fluid retention absolutely needs to watch the salt. In general, I know we eat way too much salt, and I don't know how much is the right answer.
Yeah, that's a good question. Steve, any comments?
No, I don't know what the right answer is either.
You brought up two issues, though, hypertension and heart failure. Steve, do you deal with repercussions of that in the operating room?
Well, hypertension, you can, definitely. I think that's one of the factors that results in patients that develop aortic dissections, and it's high on the list for that. So if you've got someone that's out there that is hypertensive and doesn't know it or is not being treated, they run a risk of multiple different type of vascular problems, stroke being another one. So.
Right. I know you operated on my patient. Your patient as well this last 2 weeks ago, who had a dilated ascending aorta, a congenital bicuspid aortic valve, and he bopped home doing great. I mean, I had a little more diuretic. He was having a little bit of fluid in his ankles, but he did great. Said nice things about the two of you. I couldn't understand why you did that, but
I don't think I was there that week.
So we have a bunch of questions. Here is from Custer. What causes calcification of the heart valves? I mean, I think we did address that. We don't really know. There's been some word about people taking calcium supplement, and that there is more vascular disease in people who take calcium supplement. Do you know, either one of you know?
I haven't seen any literature to point that out. I don't know if Bruce has. You might through your literature, but I don't know.
I don't know. In the renal patients you've seen, obviously there seems to be a little bit more calcification and difficulties from a metabolic aspect. Calcium lay down on the valves, again, I think is just more of a way for the body to try to stabilize what it sees as perhaps an unstable portion, whether it's fibrotic or a rough spot, or just to stabilize.
So it's part of our own healing process. I mean, I always think that our bodies are completely replaced every 7 years. Mm-hmm. I mean, we're just a figment of, we're a map.
Good point.
Yeah, and so our body does put that calcium in there. Must be a reason. Right. Does cause aortic valve disease. So
absolutely.
Mm-hmm. Here's from Aberdeen, 70-year-old on Pradaxa, which is a blood thinner like warfarin or Coumadin, a bit different. Mm-hmm. She has to go off the medicine for a dental procedure. How long can she be off the Pradaxa before her stroke rate increases? I would presume she's in Pradaxa for atrial fib. Yeah. Talk to me about.
Well, that's always a very good question. And first off, can the patient come off of it? The majority of patients can, but if somebody has had an established stroke from atrial fibrillation or a previous stroke and is on anticoagulation, I would absolutely
bridge
them, cover them with something else. If you've not ever had a stroke, you can go off of Coumadin. It's not risk-free, but the stroke risk is 5% per year. So if you're off of Coumadin for 3 days, you have 1 out of 365 times 1 out of 365 times 20. So it's low. It could happen, but it's safe, and we generally accept it.
Yeah, and I'm not into using a lot of Pradaxa yet, or any of the other thinners. I use I'm an old guy. Hard for me to learn a new thing, you know. Mm-hmm. It's not that there isn't a place for them.
Right.
There is a place for them, but I'm still using warfarin, and I would, if it's atrial fibrillation, which is an irregular rhythm of the heart, that's the reason why this person is on Pradaxa. Stopping it for 5 days, I think, is perfectly all right.
Yep.
Right.
Yeah.
I agree.
Caller has a vegetative growth on his mitral valve since birth. How can he tell if his heart's beginning to fail? Talk to me about mitral valves, Steve.
In our practice, we see a high percentage of what we see is from mitral valve insufficiency, a leaky valve. very infrequently we see the other tight valve called mitral stenosis, and you see that from typically from rheumatic heart disease years before. So mitral insufficiency, there again, can be an aging process. We see a lot of older individuals come to us through cardiology with a mitral valve that's incompetent and leaking.
Is there a clue that it's time to do surgery? I mean,
well,
do they have to go to failure before
typically
you do it?
when they start to get symptomatic, you start to tell them that, yeah, it's probably time. Now there's been new, and Bruce may be able to address this, there's been new indications over the last few years, the size of the ventricle, and as the dimensions start to change with the mitral insufficiency, you may be able to go and reasonably replace that valve before they get symptomatic.
So we're doing that, we're repairing mitral valves, not replacing them with mechanical valves or even biological
Right.
valves.
The trend over the past few years now is if you can repair a mitral valve, that's what you'll want to try to do. Not every mitral valve problem is repairable. So we do still do a fair amount of replacements, but you know, if it's a particular area on the valve that we know that we get good results with the repair, that's what we'll do.
Show us about the mitral valve a little bit more. Oh, I just pointed at the tricuspid valve. Let's erase that and let's start again. Where's the mitral valve? And
well, this is the left atrium right here.
no, I think this is the aorta, right? No, you're right. You got it. You got it. That's the left atrium.
This is the pulmonary veins that lead the blood, the oxygenated blood from the lungs into the left atrium and then down through the mitral valve, which is right here. And then from the left ventricle it goes out the aortic valve to the rest of the heart. So this is where we see the problem is with this valve. It can leak. It's got two leaflets, an anterior leaflet and a posterior leaflet, and we most commonly can repair the valve when the posterior leaflet.
Show me which one is the posterior.
Well, it's probably this one right here, and it prolapses up so that the little tendons that hold it down to keep it from prolapsing may burst or break, and then it flips up so that the blood now leaks back up into the atrium, and that's where these patients get symptomatic.
All right. And so you repair them. That's the mitral valve question. That's a great story. Here's from Sioux Falls, 50-year-old had a loop placed in her heart after decreasing heart function, still suffers from shortness of breath as it related to the loop. There's a loop in the heart after decreased heart function. Bruce, what is that?
A loop in the heart.
How about a heart, let's say you have end-stage heart failure. Are we doing augmentation pumps or?
Right. There are a number of devices that can be used to support the ventricle when it's become end stage. The current support that we have, we use intra-aortic balloon pumps. We soon may be using a device called an Impella device. This is for the acute stabilization of a post-op patient or somebody in shock with what we're doing. Currently, not being a transplant center, we do not profess to have expertise in left ventricular assist devices or right ventricular assist devices, but as we move on with more and more heart failure patients, those affiliations will become known and it'll be more of a common procedure. And I'm sure Steve might have had some experience doing LVADs in those, but right now it's not been something we typically...
In the practice earlier, I would put LVADs in, and in my training we did transplant, but there again, that's a specialized area that you got to be doing a lot of those to be proficient.
An LVAD is a left ventricular assistance device, and their pump is outside. Well, their batteries are outside, and they have a pump that augments the heart to try to get them by till they get a bypass.
Correct. Yeah, there's
heart surgery.
different forms, but that's the basic plan.
Dick Cheney lived with for 3 years.
Right.
Wow. Take-home messages that you want to make sure that you said. Bruce, 30 seconds for a take-home message that you want to make sure that people hear from you.
Well, like I say, I think heart disease is on a continuum. I mean, the warriors out there, your primary care physician, taking care of you, reviewing your numbers, listening to your heart, asking them questions. Bring questions to your appointment. That's the most effective way to say, hey, should I be on cholesterol medicines, or what are my risks? What can I do to improve my heart health? And it doesn't take a specialist or a panel to determine what's best for them. They know there are guidelines out there, and they're readily available.
As a primary care guy, I really appreciate the cardiologist saying that. I really do.
It's important.
Steve, take-home message, 30 seconds.
Well, I agree with Bruce. There's a lot of things people can do to help themselves with the heart and pay attention to it. If you have a particular family history of heart disease, it may be coming down the road, so you gotta keep your mind open about that. And once again, get in to see your doctor. He's going to tell you what you need to do and where you need to go, and that's your best source. Stay healthy, exercise, and quit smoking.
Yeah, I love that. Exercise and quit smoking. We'll be right back after this.
The flu bug is getting ready for another season. Are you? Get vaccinated, because stopping the flu starts with you.
Joe was a middle-aged guy, smart and full of personality. He had developed Hodgkin's lymphoma a number of years back, had chemotherapy and radiation to his chest as part of his treatment, which successfully shrunk the malignant lymph nodes there and brought him back to a normal, cancer-free life. Recently, he had been waking up in the night, though, feeling like he was suffocating. He told me he would go to the window, throw open the sash, and breathe in the cool autumn air to get relief. For a week now, he found that he was more comfortable sleeping in the recliner. He had also noted that he had been having trouble walking any distance, and he got short of breath just coming up from the basement. On exam, as I listened to his lungs, I could hear crackles. And as I listened to his heart, I noted it was beating 100 times per minute. Sounded like a horse galloping. His neck veins seemed distended, and there was swelling in his ankles. He wondered if there was something wrong with his lungs. The problem was not with his lungs, but rather with his heart. Although the name for this condition is called congestive heart failure, I think the word failure sounds too doomed and guilt-ridden. I would rather it be called heart weakness instead, because we have treatment to remove the excess water, ease the load on his heart, and there shouldn't be doom or guilt about it. Normally, blood returns to the heart from veins into that mighty pump as it fills and dilates during relaxation phase. When the heart squeezes, the entrance valves slam shut, and the only way out is past the exit valves. Repeating this cycle with relax, then squeeze, past one-way valves, the heart pump pushes blood out to supply every cell with oxygen and nutrients needed to flourish. Causes for heart weakness are myriad, including long-standing high blood pressure, blockage of coronary arteries, a lifetime of excessive alcohol or inadequate nutrition, viral infections of the heart muscle, valves that leak or are too tight, and the list goes on. Joe's heart was weak partly from radiation injury and probably from a viral infection. Just the right balance of medications gave him relief and hope for a future. Well, this brings us to the quick end of the show this evening. I sincerely thank our fantastic guests tonight. They brought a great level of expertise to these very difficult questions. As often happens on the show, time ran out. We didn't get to all these questions. So to hear our answers to more of these questions, please join us now on our website, oncalltv.org, where we'll continue live with On Call After Hours on the web in just a few minutes. Mark Twain knew the worth of a heart when he wrote, "It's in the heart that the values lie, that a loving heart is riches, and that without it, intellect is poverty." And until next time, stay healthy out there, people.
concerns we should have as we grow older, and what all does our nervous system do? It is your chance to ask the experts about neurology and adult health. Next time on Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us. We want to answer as many as we can for you, so let's go right at it, boys. Caller had atrial flutter that was converted 5 years ago. What caused it? How is this different from atrial fib? So atrial fib flutter, what is it? And
atrial flutter is where the upper chambers of the heart, the atrium, are beating very fast, usually around 350 beats a minute, and give a fairly regular signal to the lower chambers of the heart, whereas atrial fibrillation, the upper chambers are beating over 1,000 beats a minute, very fast, erratic signal to the lower part of the heart. Causes of atrial flutter and fibrillation are often quite the same, and there's a long laundry list of those, but yeah.
All right. Caller's been told she can't eat green vegetables while on warfarin. Why? And could aspirin replace the warfarin? Steve?
Well, the green vegetables carry vitamin K, and that's how Coumadin works, by inhibiting vitamin K. So if you're on warfarin, and particularly broccoli is one of the worst, and you're consuming quite a bit of that, you will not get the effect that you need from your warfarin or Coumadin.
I always like to tell them, eat your vegetables, but eat them every day the same, so that
right.
you know,
Great
we can be
advice.
consistent.
Consistency.
Yeah, 52-year-old son has idiopathic cardiomyopathy for 15 years. Idiopathic cardiomyopathy, has a pacemaker and a defibrillator, also has a muscular dystrophy. Is there a connection between the heart problem and the muscular dystrophy? Bruce?
Yes, very many patients with particular types and forms of muscular dystrophy can have cardiomyopathy, and it's a part of the muscular dystrophy. It's very important, though, to be sure there are not other family members that have had sudden death episodes or episodes of unexplained syncope that have the other forms of inherited cardiomyopathies, which can be fatal.
Right. Well, this person has a defibrillator, and so I think safer.
He's very safe, yep.
Very good.
And the assumption is that it's related to the muscular dystrophy.
And that's that heart idiopathic, meaning we don't know why it is, but it's weak. And actually, it's probably muscular dystrophy.
It's probably muscular dystrophy in that particular situation.
There's a new drug from Novartis. He said it was a breakthrough for heart failure. Is it available in Sioux Falls? Either one of you know a new heart failure drug?
No, I do not know.
From Novartis.
From Novartis.
I'm thinking it could be the major drugs are spironolactone,
Right.
a beta blocker like carvedilol or toprol,
Right. It may be
and diuretics.
It would probably fall within the pre-existing classification in some form.
Maybe the new spironolactone. That's the other one, spironolactone. There's a new spironolactone.
There's eplerenone. That's Inspira, though. So it may be a new ACE inhibitor or something in that.
All right. So an ACE inhibitor, beta blocker, diuretics, spironolactone.
Mainstays
of heart failure. Discuss the heart disease risk for a diabetic. Steve.
Typically what they get small vessel disease. Their coronary arteries get diffusely diseased, and we'll see that quite often. And those are actually some of the patients that we do bypass for and have better results. Multi-vessel disease in a diabetic have fairly good indications for surgery.
I went to an international internal medicine conference. They said diabetics need to go probably to surgery more than
Right. And to address what is the heart risk of a diabetic, it's a coronary artery disease equivalent. You have atherosclerosis if you have diabetes, and need to address it as a...
Here's Rapid City. Man in his 60s has gained 70 pounds in the past 10 years after a very active lifestyle, running 35 marathons, doing Ironman even. How can he get back into exercise and save his heart? You recommend a treadmill stress test before he gets back into it?
Yeah, I first look into the causes and make sure that it certainly is just a lifestyle issue. Oftentimes middle-aged men will develop sleep apnea, have increasing fatigue. We didn't get to talk a lot about sleep apnea, but that's one of the causes of increased fatigue. Testosterone levels can drop at that stage, increased body weight. So you want to make sure there's not some other cause such as hypothyroidism, but once those things have been looked at by their primary care physician, a routine stress test, you don't need expensive imaging, just to make sure it's safe to get your heart rate up and start exercising.
And get going, do it slowly. Don't hurt anything on the way. Start with good brisk walking, that's all. Brandon, is there a risk of taking too much fish oil or for too long? Any comment about fish oil, Steve? You a believer in fish oil?
I am a believer in fish oil, but I don't know if there's any correlation if you take too much.
Too much. Get a little diarrhea.
You'll hear from your family members in the house. There's not too much risk of taking too much of that. It'll correct.
But there's something that goes with that. What causes an enlarged heart, and what problems will it cause? An enlarged heart is heart failure, and there's a lot of causes.
A lot of causes, it is.
Yes.
Two biggest causes, hypertension, making your heart very muscular and very big, or a dilated heart that's not pumping very well are the most common causes.
Okay. Aberdeen, 85, your reactions, new Coumadin replacement drugs. Great question.
I'm with you, Rick. I'm a warfarin guy, so I don't have much experience with the new ones, although I see the patients come to me prescribed the new ones through cardiology or internal medicine.
4 times more expensive. We're not sure about how safe they are. They're brand new drugs. But I see some people who can't take warfarin. It's a reasonable option. What's your take?
I think it's a reasonable option if they're having a lot of difficulty with fluctuating levels of their INR at age 85 with appropriate body weight, normal kidney function, a lot of good data showing some clinical superiority in certain individuals.
Well, one thing I add for the surgeon, valve disease, warfarin is the only thing that you can use. So in my practice, that's what we use.
If you have heart palpitations, at what point should you see your physician? Are some palpitations normal? The answer is yes. Everybody has palpitations. Right. I mean, they learned that doing Holter monitors on med students. Scared them, oh my gosh, we really are in trouble with this sick patient. Let's do a normal.
Right.
Oh, the normals are the same way.
Right, right. Palpitations that make you short of breath, come on suddenly without warning, like a light switch on and light switch off, make you feel lightheaded or associated with chest pain.
That's another story.
Another story.
What causes thick blood? What risks, if any, does this pose? Thick blood.
Smoking, polycythemia, low viscosity of the blood. Don't smoke.
Don't smoke.
But
and there's some people who have hypercoagulable states they inherit or they acquire.
Right.
That's another.
They usually show sometime with a DVT or a pulmonary embolism.
Yeah, clot in the leg, blood clot to their lungs.
Right, and it's usually not as you could look at it and say one's thick, one's thin. When we say thinness, we're talking about coagulation factors, what makes the heart clot, the blood clot.
Discuss tricuspid valve problems. You ever do surgery on tricuspid?
Yes, actually the trend now is with patients with tricuspid insufficiency of a degree greater than mild, we usually try to do something with, and repair is the primary modality. A lot of times you can go in there and just cinch down the tricuspid valve and get a good result with that.
But sometimes they say if you've got tricuspid regurg, it's just an indicator of pulmonary hypertension.
It can. A lot of patients with tricuspid regurg will have pulmonary hypertension, so you do have to be careful. If there's a component of right ventricular dysfunction, the right side of the heart isn't working very well, they've got pulmonary hypertension and a tricuspid valve that is quite insufficient, then you got to be real careful with those patients.
That's a tough story. Any comment?
That's a tough deal.
Yeah, wow.
Yeah, I think the surgeon's just looking for things to do. No, when we were in medical school, they would always say, because everybody they would have right-sided endocarditis, and many times they would have to cut the tricuspid valve out. And you live without a tricuspid valve, but you want all 4 valves.
Yeah, you do.
Yeah.
Caller has fibrillation, exercises, feels okay. What does it mean for her future? I have people with atrial fib, and they live normal, full lives.
Right.
And what do they lose? 5 or 10% of their squeeze. But they can get used to it, adjust to
Right.
it.
Yeah. In fact, oftentimes once they've adapted to it, their squeeze can stay the same. It's just they lose the forward output. But many people, if they have a good functioning ventricle, aren't reliant upon that squeeze. So, good prognosis as long as they are protecting against stroke.
Right, and most, even the people that you normalize back into a normal sinus rhythm, many times you still keep them anticoagulated, although not always.
Quite a bit of the time you do. It's just, especially if they never knew when they went into it. If they have no way to know when they went into it, you only need to be in for 2 days to form a clot, and then your risk is back to that 5% per year.
Yeah. What causes a irregular heartbeat? We've talked about that. 80-year-old woman has a hole in her heart. Should she be concerned? So this is atrial septal defect, probably. A ventricular hole between the ventricles needs always to be repaired, correct?
Yeah, that's a different animal.
But an atrial septal defect, what?
In an 80-year-old, I'm not sure I'd do much about that unless there were symptoms.
And if you did autopsy on 100 patients, 27 of them, you'd be able to stick a pin through the patent foraminal valley. So it, without knowing more about the hole,
So if I see an echocardiogram, I do an echocardiogram and I see flow going from the right side back to the left side, I'm worried about having lost our greatest body clot filter called the lung. And that clots can flip in there and people can have strokes. So I worry about those. Do you repair those typically?
Now they usually just go in interventional.
With that little umbrella thing.
Amplat's occluder and take care of it that way.
And again, it takes the right person doing that. You just don't do it on everyone. They're usually oftentimes in a trial. They need to actually be proven that they had an embolic event for no other reason that the size of the hole and the anatomy is appropriate for it, but it can be done all without having to have an open heart surgery.
Right. The thing about it is suddenly everybody was doing that. Everybody who had a septal defect, 27% of the population, were getting those little devices at the tune of $20,000 or so.
Unfortunately, it hasn't panned out to be as preventative as we think, and there's still a number of patients having strokes even with those devices in.
Yeah. So something else was happening. This is, we've answered atrial fib question again. What is ejection fraction and what is normal?
Ejection fraction is just the amount of blood from the main pumping chamber that gets pumped out in one cardiac cycle. And for a surgeon, if I see somebody 50 to 60%, I consider that normal. Right. I don't know if I think cardiology.
And the good thing to know is that if somebody tells you have an ejection fraction of 50%, don't be depressed for a whole year and then ask, what does that mean?
Yeah.
Because I've had patients thinking 100% is normal. It's not. We don't pump out all the blood in our heart. It's between 50 to 65, 70%.
Yeah. And people can live very well, but when you get less than 10%, you're pretty close to the end, aren't you? Now, they talk about putting in defibrillators at 30% or less because these people are at risk for sudden death. What do you think of that?
Yes. For patients that have had a sequence of heart attacks that have left their heart with a pump function less than 35%, or in a patient that has idiopathic, or we don't know why, cardiomyopathy below 30%, they're at significant enough risk of sudden cardiac death that after treatment, trying to get them the best that they can, they haven't come above those numbers, it would be indicated to have a defibrillator.
So 30% is the number you like, EF of 30% in a reasonably young person?
30% in an idiopathic, but 35% in an ischemic cardiomyopathy.
Oh, okay.
They're a little slightly higher because of the scar formation.
Yeah, that's interesting. But that's an expensive deal. I mean, it isn't all
Very
cover.
expensive deal, yeah.
Here's from Jefferson. Discuss ablation. What is it? How does it work? And how long does it last? Great question. We didn't.
That's a good
Ablation.
Ablation is a technique in particular mostly about atrial fibrillation ablations, but we've been doing ablations of bypass tracks and pathways where you get an abnormal circuitry within the heart, and certain types are 100% treated and don't come back. Patients with a condition called Wolff-Parkinson-White, where it's an accessory, we have excellent success with that.
So these people have these wildly fast heart rhythms
Fast
because
heart
the electrical
rhythms,
system is
right.
bypassed.
can't be controlled with medicines, and it's an alternative, and it's actually indicated now for patients that have paroxysmal AFib where they feel horrible with it, and it can be first-line therapy. And we've been doing a lot of atrial fib ablations. We're very fortunate. We just got a brand new South Dakota boy from Yankton, John Adams, who I've had the privilege of mentoring through his medical school career, but he just came back from Stanford, did his EP fellowship, and has some new devices and new mapping techniques.
Stanford in California.
Yeah.
And so he's got new techniques, and
Well, new techniques. We have some new equipment that really cuts down on the mapping time. These procedures are very laborious and long, but boy, he can get in there and you can identify it quite quick.
So that has to do with abnormal heart rhythms, and you just go in there and you zap the short.
Right.
Cut out the short. 62-year-old mitral valve prolapse, no known problems, taking atenolol for 30 years. Well, I need this valve replaced, and what age should be the cutoff for replacement from Sioux City? Well, mitral valve prolapse, we talked about that
He's
earlier.
a typical patient that if the dimensions of the ventricle are getting larger, he's into moderately severe to severe mitral regurgitation on echocardiogram. Without symptoms, you can reasonably tell this patient, if you think you can repair it, that's the treatment of choice.
But we're not repairing all mitral valve prolapses, are we?
Right. I mean, he's had it for 30 years.
Yeah.
He may not have any leakage at all. It's just prolapse. And he can stay like that for the rest of his life.
Yeah. So, well, thank you very much, both of you, again, for joining us and for staying afterwards for a ton of questions. And thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at 7 o'clock Central Time. Call in your questions or email them. Watch for our Prairie Doc Perspectives column in your local newspaper. Listen to our Prairie Doc Conversation radio show on a station near you, and follow us on Facebook, Pinterest, and Twitter. Next week we'll be talking about Ask Anything Internal Medicine and Neurology. So until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doctor is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubak and the Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Community, and Swiftel Communication. Closed caption for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.